Good afternoon and welcome to the GAPNO webinar, Parkinson's Disease and the Role of the Advanced Practice Provider in Diagnosis and Treatment. I am Christina Ramsey and I'll be your moderator for today's webinar. Participants in today's webinar should complete the process for this non-CE event by evaluating the webinar at the end of the session and retrieving their certificate of attendance. Before we get started, I'd like to take a moment to review some of our technical features. We would like today's webinar to be interactive, and we encourage you to submit questions to our presenters using the Questions tab on the left-hand side of your screen. Please feel free to submit your questions at any time. Our speakers will do their best to address your questions verbally at the end of the program. If you'd like to take notes, please click on the Notes tab to the right-hand side of the screen to utilize the text box. Your notes will be emailed to you automatically at the end of the presentation. Also, if you experience any technical difficulties during the course of the webinar, you can click on the Request Support button in the left corner of the player to receive assistance for our technical experts. Now I would like to introduce our speakers. First, we have Dr. Yusar Torres-Yaqui, who has joined the staff as Director of Parkinsonism and Dementia Clinic following a Neurorestoration Research Fellowship at the MedStar Georgetown University Hospital. Dr. Yaqui is also spearheading an initiative to care for the growing population of aging patients with neurodegenerative conditions characterized by overlapping features of both cognitive impairment and Parkinson's disease. Dr. Elham Kobahi is currently working as a clinical pharmacist at Parkland Hospital in Dallas, Texas. Previously, she worked as a clinical advisor at the Hospice Pharmacy Solutions in Richardson, Texas for over 4 years. She graduated with honors from UIW School of Pharmacy in San Antonio, Texas. Prior to entering pharmacy school, she devoted over 2 years to clinical research at UT Southwestern Medical Center. And then lastly, Christina Ramsey, myself, has over 30 years of experience in providing long-term care consulting. I have worked as a gerontological nurse practitioner in many nursing homes in San Antonio and New Braunfels for over 12 years. I'm presently owner and operator of C.E. Ramsey Resources, a consulting business in long-term care. I've provided consulting services in 6+ states for long-term care regulatory requirements, to establish programs and systems to improve quality of care and quality of life for the elderly, as well as providing training at all levels of employees in long-term care regarding regulatory requirements and standards of care. I received my MSN degree and gerontological nurse practitioner certification from the University of Texas Health Science Center in San Antonio. So we're going to go to the physician section and start our first polling question. If you could answer, what is the basic criteria for deep brain stimulation in a Parkinson's patient? A, when the Parkinson's medication becomes ineffective. B, within 4 years of being diagnosed with Parkinson's disease. C, when the patient is still responding to levodopa but can't control symptoms with medication alone. Or D, when the patient starts to develop cognitive impairment. So if you could mark A, B, C, or D. And we will give a few seconds for that. We'll be watching the polling answers. Okay, looks like we're getting some results here, and we have 63% with C, when the patient is still responding to levodopa but can't control symptoms with medication alone, which is the correct answer. Great, so we're going to move into the physician's portion of the presentation, and Dr. Yagi will start off with diagnosis, symptoms, risk factors, complications, to just give us a brief overview of all that. Dr. Yagi?
What a wonderful introduction, Christina. I am honored to be on this panel with Carly, you, Christina, and Elham. It's so nice to be able to sit virtually, present on this important topic. I wish all of our clinics in the country taking care of Parkinson's patients looked just like this panel, you know? So like an outreach person that's helping educate. We have a wonderful a nurse practitioner or an advanced practice provider like you, a clinical pharmacist. You know, I'm just one cog in the wheel. There are too many factors that are important to focus on. In a Parkinson's world, if we could create patient-centered medicine so that these patients would have education from all sides, from the pharmacist to the nurse practitioner to the medical assistant. You know, the MD, the DO, or the subspecialist in movement disorders is one piece of a huge team. We always say it takes a village, and that's the truth. It takes a village to take care of our patients. And in particular, if we look at this slide, it takes a village to follow our patients down the diagnostic journey at times, right? There's two parts to this, our diagnostic journey and our therapeutic journey. And they're two long journeys at times. And sometimes thinking about the diagnosis, in addition to it being a very clinically embedded diagnosis where you use your clinical examination to diagnose Parkinson's, remember, we think and we listen. Our goal is to have big ears, you know, have our ears on, make sure we're listening to our patients to understand all of the things that can happen in Parkinson's disease, starting with the non-motor symptoms, right? At year zero of diagnosis, let's say we diagnose someone right now, it's not uncommon for non-motor symptoms to precede the motor symptoms. Now, what are the motor symptoms? We think about them as slowness of movement, gait impairment, rigidity or dystonia, and or tremor. Now, listen closely. Tremor does not have to exist for a diagnosis of Parkinson's to occur. Now, beyond that, decades before the tremor, rigidity, slowness of movement, and gait impairment bring us to our neurologist or our movement disorder specialist for diagnosis, it's not uncommon for us to hear that decades prior, our patients may have been suffering from anxiety, depression, anosmia, lack of sense of smell, constipation, REM behavioral sleep disorder, which is our inability to stay controlled and paralyzed during REM sleep. So as we go through the process of diagnosis, we have to then also understand all of the things in addition to the motor symptoms that can happen. In particular, let's draw our focus to cognitive difficulties. I am the Parkinsonism and Dementia Clinic Specialist at Georgetown University Hospital. I'm in Washington, D.C., but funny enough, I'm a Texan at heart, so I'm glad to be part of this. I was born in Austin. My grandfather practiced in Dallas in the hospital that was once called St. Paul. He was an ophthalmologist. And my great-grandfather was a primary care physician in San Antonio before penicillin. And so wonderful to be able to talk to everybody. But remember, it's not all about the movement. Cognitive difficulties occur, depression, as we talked about, sleep. Sleep fragmentation is the most common problem in our patients. It's not about falling asleep. Patients might fall asleep easily. We talked about acting out our dreams, but let's not forget, our patient has trouble staying asleep. That's called sleep maintenance insomnia. Patients might find it hard to turn in bed and things like that. And then as the disease progresses over time, more and more of the cognitive and neuropsychiatric symptoms become more apparent. And dementia-related psychosis does and can become the centerpiece of the diagnosis. Now, I tell you all of this only to have a therapeutically driven conversation. Remember, in 2022, a lot can be done to treat our patients. In 2022, it's very different than 1972 when all we had was carbidopa, levodopa. In 2022, we have about 30 different options, therapeutic options, to treat our patients. So the future and the present are bright and optimistic and hopeful, and I want everyone to know that, especially with a team like this, with advanced practice providers, nurse practitioners, a clinical pharmacist. I mean, if we could take this on the road and just take care of patients all over the country, that would make me happy. But remember, we have tried and true therapies that have been around for a long time, but then we have new and emerging treatments. So that means in a big clinical practice academic center like mine at Georgetown, we have about 14,000 patients. We have 12 different movement disorders doctors. We have anywhere between 10 to 15 clinical trials ongoing at any moment. So we have so much research momentum. And just in the past 5 years, there have been new and emerging therapies come through the pipeline to be able to make a change for our patients. Since 2017, I tell you, there have been so many advancements just in the field of what we can do for on-demand or as-needed therapy, for dementia-related psychosis, for levodopa-induced dyskinesias. Now, it doesn't mean that all these oral therapies, even though we utilize them and they're helpful, doesn't mean that we don't oftentimes get to a point where we need a procedural treatment option. And those procedural treatment options are continuing to advance and evolve. We have deep brain stimulation, and we have other options, including a medication infusion port. And in the future, we'll have subcutaneous medication infusion ports that go into the skin. So the future and the current state of therapeutics is bright and optimistic. And I want everyone to feel empowered with that information. Because in 1972, late 60s, early 70s, when carbidopa, levodopa immediate release was first utilized in our patients clinically, you know, that was a breakthrough, but we've had so many breakthroughs since. So as a physician, I have to tell you, we need to utilize that positive momentum in clinical research, the positive momentum with our therapeutic landscapes, and utilize them in combination. And that's called rational polypharmacy, combining different medications to treat symptoms, not just utilizing one family of drugs, not just even utilizing only oral therapeutics. We have patches that can be helpful. We even have cognitive therapies that we utilize, the medications that can also be utilized for Alzheimer's that we utilize for cognitive improvement. So hopefully we are able to think about that strategy of rational polypharmacy, use a team just like the one on this panel to teach our patients, clinically educate them about the different therapeutic options, and utilize all of those therapeutics in combination. It's not uncommon for us to have a patient with DBS also on a newer formulation of carbidopa, levodopa, and an amantadine derivative, and a monoamine oxidase inhibitor, and a dopamine agonist to create that sort of stability. And we may need to use the cognitive enhancers and medications to treat psychosis too. But the truth is, based on clinical research trials, pivotal trials, we have drugs approved for all of the things that I mentioned.
Well, thank you, Dr. Yagi, for that very inspiring review there. I appreciate that. We're going to move on for our timer constraints to the pharmacist polling question. So for you online here, what is the following drugs, or which of the following drugs or drug classes are not appropriate for monotherapy in Parkinson's disease? A, COMT inhibitors, B, dopamine agonist, C, decarboxylase inhibitors, D, MAO inhibitors. So if you could pick A, B, C, or D. The polling is open. We'll allow about 15 seconds for that answer. And our pharmacist is going to go into some more treatment options. Okay, looks like our polling is closed. And we have 43% with MAO inhibitors, 23 with the percent with the decarboxylase, and 20% with the COMT inhibitor. So the correct answer is A. So it looks like we probably need to learn a little bit more about that from the pharmacist who we have next. Ellie, if you could take that away.
Thank you so much, and I'm happy to be here. This is really dear to my heart. My dad is actually diagnosed with Parkinson's a couple years ago, so I've been going on that journey with him. I expect everyone to guess the COMT inhibitors, but it can be really confusing. There's tons of agents out there, so it was a good try. But COMT inhibitors are one class of drugs that can never be used alone. They have to be used in conjunction with carbidopa-levodopa. The rest of those options are first-line agents and can be used monotherapy. I think the tricky one was the decarboxylase inhibitors being the class that carbidopa-levodopa falls into. So before we jump into the medications, I really want to emphasize the importance of exercise in Parkinson's. And studies have found that Tai Chi, treadmill work, and resistance training, as well as yoga, has helped balance functional capacity, decreases falls, and it has an overall favorable influence on Parkinson's prognosis. So when we look at the medications we can use, we want to make sure we pick an agent that will help with them reach the maximum capacity of an active lifestyle as they can, because it has such a favorable influence on Parkinson's. Some other options we have to look at, and Parkinson's meds are very patient specific. The whole therapy is individualized throughout the entire course of the disease. So you look at the symptom type that they're experiencing, the severity, the stage of Parkinson's they're in. The age is very important, comorbidities, as well as how they can tolerate the different medication classes available. And there are so many classes available. There's about 7 different available. Unfortunately, none of them have convincing evidence that they can halt or the progression of Parkinson's or cure it. So when we talk about medications, it's strictly symptomatic benefit. And we'll start with our gold standard. Everyone knows it pretty well, but it is levodopa. It's been around since the 60s, and it is the gold standard. It's the most effective option you have for symptomatic control of Parkinson's. It is the natural precursor to dopamine. And if you want to open your resources tab on the left bottom, you can scroll to, I believe it's called Parkinson's disease drug chart. If you click on that, you'll see a nice visual of how we're going to go through it. It can help guide us a little bit more. So if you open that, I'll give you a few seconds. And we'll begin again talking about levodopa. So levodopa was used by itself initially, and then it was later combined with carbidopa. Carbidopa, if you look at the picture, the top left, you'll see it blocking an enzyme. And this enzyme is responsible for prematurely breaking down L-dopa in the bloodstream into dopamine, which is not where we want it. So carbidopa came in and it blocked that conversion and allowed more levodopa to enter the brain and help the patient. So that became what's known as Sinemet. It is the most effective again and is well tolerated in the elderly, which is the main population we see diagnosed with Parkinson's is over 65 years old. It also comes in several formulations. There's an IR, there's a new ER capsule. This capsule contains beads. The beads have 2 different rates of dissolving and absorption. So they get therapeutic benefits in an hour, and it sustains in their bloodstream and to their brain for about 4 to 5 hours. Duodopa is a gel. This gel is continuously infused through a portable system the patient has, and it provides continuous dopamine, levodopa, carbidopa. Parcoba is an ODT formulation, quick onset, and most recently what's kind of cool is they came out with Inbrija. Inbrija is like a rescue inhaler, and it delivers the levodopa in an inhaler form, and it's for quick symptomatic control. So if you look at the picture again, another common enzyme that breaks down L-dopa is COMT, catecholomethyltransferase. It's a mouthful, but it is responsible for breaking L-dopa down as well. And what they came up with were COMT inhibitors, which can never be used alone again, but these work by allowing more levodopa to enter the bloodstream, the brain. So the most common one you've probably heard of is entacapone. Entacapone is given with every single dose of carbidopa-levodopa, and it works by blocking COMT, allowing more levodopa to build up in your bloodstream and enter the brain. They came out with a new agent called apicapone, and it's daily usage, which is great because Parkinson's disease comes with a really high pill burden. So if you can reduce that in any way, we try to do that. If you look at the picture again, you'll also see COMT inhibitors are located centrally in the brain. And you'll see the only agent that actually crosses the blood-brain barrier to block COMT in the brain, which breaks down dopamine, is tolcapone. This is rarely used because it has high risk and a black box warning for hepatotoxicity, requires a lot of blood tests. And then if you see, dopamine also gets broken down further by MAOB. So what they come up with, MAOB inhibitors, naturally, to increase the amount of dopamine in the brain. MAOB inhibitors can be used monotherapy. They have very, very mild benefit, but they're well tolerated and convenient and great for mild symptoms. So rasagiline is the one that you hear the most. It's the most preferred because selegiline, on the other hand, comes in ODT as well as a patch, not necessarily used for Parkinson's, but it carries a toxic amphetamine-like metabolite, which we don't want to use in our cardiac patients, and it can cause insomnia as well. They recently came up with sulfonamide, which is a new agent to this one, and it's only used as add-on to carbidopa-levodopa, and it just works the same as rasagiline and selegiline. Next, you'll see to the very right on the postsynaptic neuron, you'll see dopamine receptors, just the gates that allow dopamine to go through, send the message, and coordinate movement. So our dopamine agonists basically pretend to be like dopamine. They're not exactly dopamine, kind of like synthetic. They bind to the dopamine receptors on the postsynaptic neurons and tell the cell to send the message to coordinate movement. They have intermediate potency. Carbidopa-levodopa is still the most effective, but dopamine receptor agonists come in a close second. They're commonly used first line, mainly for young, early stage Parkinson's, but the side effects are kind of scary, especially in the elderly. There's one called sleep attacks, which is where you have an irresistible urge just to fall asleep. There's no warning. It happens suddenly, which can be really scary for patients that are still driving, still working, or need to be fully functioning awake. It also causes hallucinations, and one of the most infamous side effects is the impulse control disorders. So this can be compulsive gambling, it can be compulsive shopping, as well as some abnormal sexual behaviors. I hear that the most from my nurses when they complain about it. But it also includes a few agents in it. There's rotigotine, which is a 24-hour patch, which is great for patients that can't swallow, have difficulty swallowing. There's ropinirole, pramipexole, and apomorphine. Apomorphine is a little bit different. It's administered subcutaneously, and it also has a sublingual film. It's basically a rescue medication for when patients experience irregular off periods despite being on medication. So there's also acetylcholine inhibitors. These are infrequently used, but they restore the balance between two brain chemicals, dopamine and acetylcholine. So when dopamine goes down, you see acetylcholine go up, and it causes impairments in movement. So what we can do is use anticholinergics to bring down that acetylcholine. This is only used in very young, early stage patients with severe tremors. It is actually one of the most harmful medications you can give an elderly patient due to the side effects of dementia, hallucination, constipation, confusion, and urinary retention. And then in its own class, you'll see in that picture amantadine. Amantadine is actually an antiviral. It was used to treat influenza A in a patient that had Parkinson's, and it just turns out their Parkinson's symptoms became better, improved their symptoms. So now it's used for Parkinson's. The MAOA in Parkinson's, the mechanism of action isn't really fully understood, but it does increase dopamine synthesis as well as decrease the reuptake of it. Another agent that stands alone and is really new is the estradiol. This is used adjunct to carbidopa-levodopa to treat off episodes, which we can go into later. It cannot be used monotherapy, and it boosts dopamine signaling by, and this is why it's on a class of its own, it antagonizes adenosine A2A receptors. And should all the medication management fail, you always have deep brain stimulation that can help with resistant symptoms as well. So sorry, it was so fast and furious. There's just so many options there, but that is about it for now.
Well, thank you, Dr. Kobahe. It sounds like we really need to have our pharmacists involved in our care of our Parkinson's patients, because that is really technical in some aspects.
Yeah.
Okay, so moving right along, we're going to go into the nurse practitioner polling question. And we're going to start off with the role of the NP, or advanced practice provider, in diagnosis and treating patients with Parkinson's disease includes all but A, manage issues early and proactively. B, facilitate access to specialists as soon as possible, i.e. neurologists. C, wait on the neurologist to diagnose and treat. D, deliver personalized care. And E, collaborate with patient caregivers on patient treatment. So we'll open the polling on that. Allow another 10, 15 seconds. And then we'll jump right into the APP section. Looks like our results are coming in, and 79% C, wait on the neurologist to diagnose and treat, is the correct answer. Very good. So going into the nurse practitioner section, let me get that slide up. So the role of the advanced practice provider in diagnosing and patients with treating patients with Parkinson's disease is going to be affected by the practice setting because that will determine your role. In long-term care, the APP becomes the primary provider, and often you're the gatekeeper for all aspects of care and medication management. You may be the only access to health care until a specialist can be seen. Home or office visits may require that you gather more information and assessment from family or caregivers if you work in an office setting. The level of experience of an APP also affects how the patient is treated. I have precepted many NP students and trained new nurse practitioners in long-term care. And what I have seen is a lot of new practitioners refer all their patients out to different specialties. They don't even want to work them up first for differentials for fear that they might do something wrong. So the advanced practice provider needs to have a broad knowledge base about Parkinson's. They have to have good observational skills and have recurrent patient contact so that will allow them to be able to identify and manage patient symptoms more easily. Now, this is an advantage of long-term care because normally you're in the facility often and have interaction with these patients more frequently than in an office setting. While there's typical symptoms of bradykinesia, rigidity, unstable posture, and tremor, many patients' symptoms are unique to them. And so knowing those symptoms is very important. Completing a detailed history and workup for differentials will help the neurologist and identify early things that we can go ahead and provide interventions for. You know, managing those issues early is really important. Depression is common. As much as 50% of Parkinson's disease patients do have depression. Often it goes underdiagnosed because the symptoms of Parkinson's also can go along with the symptoms of depression. So we can't wait until a neurology consult. We do need to go ahead and be identifying these symptoms that are interfering with ADLs and quality of life. Access to a neurologist also can be difficult in the long-term care setting. Some of my colleagues in the Northeast work in large skilled nursing facilities. They have hundreds of patients and their specialties come into the facility. I work in the South and a lot of the specialties do not come into our facility, so we do have to refer them out. The scheduling can be weeks or months out. So it's very important to collaborate not only with your practicing physician, but also developing those relationships with the neurologist so that you can address more urgent issues without having to wait for that office visit. I know that has helped me to have them as a contact that I can text them about a patient if I need to. So that's really important. And then the next thing, if we look at the lifestyle home remedies we're looking at medication management, and this is a very important aspect of the advanced practice provider role in caring for the Parkinson's patient. There's a lot of remedies on the internet for all different kind of disorders and disease processes, including Parkinson's disease. Medications that claim to control tremors, curb behaviors, increase brain performance. One supplement I found literally is called Parkinson Remedy. It contains composition forms of haloperidol and reserpine over the counter. So we really need to be aware of what our patients are taking, their Parkinson's medications as well as OTCs. Scheduling medications are very important. Some have adverse effects, so it's better to take those in the evening or the night. And then there's medications like carbidopa, levodopa that need to be spaced out appropriately to prevent medication failure or when the medication wears off. Another area is therapy services. They can provide at the first onset of physical or cognitive declines intervention. Research has shown that therapy provided to the elderly Parkinson's patient frequently decreases physical functioning declines and adverse effects from the progression of the Parkinson's. So 2 to 3 times a year is a good way to keep your patient moving. Related to nutrition, the Parkinson's Foundation said that there's not a prescription for Parkinson's disease and that the best diet for the patients is the best diet for most people. So a balanced diet of fruit and vegetables, proteins and grains. They do have some more specific recommendations on their website for teaching patients about foods or fluids that may interfere with their medication absorption. And then lastly, mobility. That is always a challenge. I myself care for my elderly Parkinson's father who lives with me. I know that this is a constant challenge for us. You have to encourage your patients, encourage the staff at the facility, if they're in a skilled nursing facility, that they have to keep moving as long as possible. You want to prevent the utilization of wheelchairs for convenience. Even as it becomes more difficult for them to perform their ADL task and ambulate, it's always best to keep them moving so that they can maintain those abilities and safely as the other portion of that. So I know that with my own experience with my father, he's always looking for something quicker to get him to perform those. And I keep telling him if he stops moving, he's going to lose a lot of that function. Okay. So now we're going to get to the question and answer section, and we're going to look at some of the questions that have been submitted into us. And I'm going to start off with the first polling question is for Dr. Yagi. Can you tell us some more about Parkinson's disease psychosis?
Yes, definitely. It's a very important topic. Thank you for asking that question. Whenever we see Parkinson's disease psychosis related to the diagnosis of Parkinson's disease, we always need to understand what sort of psychosis or delusions our patients are suffering from. Remember, detection is a major problem. I loved hearing that the answer to that last polling question was that we don't wait for a neurologist or subspecialist to make the diagnosis. We have to do everything we can. Probably about 10 to 15% of the patients in the country are seeing subspecialists. 85% of Medicare prescriptions, after a study we did auditing the prescriptions of just carbidopa, levodopa, are in fact coming from non-neurologists. So they're coming from general practitioners, they're coming from advanced practice providers. So it's important to detect something when it's there. Oftentimes, it won't necessarily in a clinical evaluation be told to you. You have to put on your investigator hat. In medical school and in residency fellowship, you put on a hat and you put on different hats. You may put on your psychiatry hat, But oftentimes you're putting on your investigator hat and you're asking questions to detect disorder, right? Because we know Parkinson's is a progressive disorder. If psychosis is present, we tend to call that the malignant phase or one of the end phases of the disorder. So it has to be addressed. And the questions we ask in clinic are you seeing people or animals in the room that might not be there? Do you sometimes feel the presence of animals or people or spirits in the room that might not be there? Because you may not necessarily see things, but you may feel things. What about looking outside the window and a tree looks like a person momentarily, or a belt on the floor looks like a snake momentarily? That is called an illusion. It is part of Parkinson's disease psychosis. And then, of course, there's something called passing hallucinations. Patients may feel like something's passing in their periphery. So first of all, you have to make sure that you're understanding whether or not psychosis exists. And then you want to differentiate it from delusions. Remember, delusions are a fixed idea. It's an idea that gets stuck in our mind like a paranoid thought that people are coming in the house or our partner is in fact doing wrong to us as a patient. There's also different types of delusions called capgras or frigoli, where you confuse your partner either for a stranger or you confuse a stranger for your partner. Another type of delusion is feeling like you're being financially persecuted, like someone is going to take your money. And remember, we have to address it because there are many treatment options now for Parkinson's disease psychosis. In 2022, there are many options, and we have an FDA-approved medication, in fact, to treat Parkinson's disease psychosis too.
All right. Well, thank you for that answer. We have a question for Christina. What are the challenges you have faced in treating patients with Parkinson's disease in your practice? Well, two come to mind. I think that scheduling medications is, especially in long-term care, but in all settings, is very important. The APP needs to ensure the medications are given and taken appropriately, especially when it's identified that the patient is having frequent medication failures or a decline in ADLs or physical functioning. You know, this is a challenge in long-term care when they have set administration times and the staff is already pressed to get all their tasks done. You know, it's a bit easier in managing medications in states that have medication aids because that's all they do is pass medication. So they have a little bit more flexibility than other states where the charge nurse is doing it and she doesn't have much time. So the APP needs to be aware that after taking levodopa, sometimes typically after a few years, the patient may start experiencing wearing off periods when the symptoms return before it's time for the next dose, and that these can last from 15 minutes to a couple of hours, and that during these times when they have the wearing off, that they may have what some people call Parkinson's freeze, when their muscles don't respond, which leads them to falls, injuries, or other ADL dysfunction. So taking their medication as prescribed on the time schedule is very, very important. The other is preventing mobility or physical declines. I know it's hard to keep elderly people moving, especially in long-term care. And Parkinson's patients often want to revert to an easier, less physical way of doing a task, which may be using a sit-to-stand or a wheelchair. The problem is once they or the staff revert to these devices, the patient will lose function quickly. Now, we can provide therapy 2 or 3 times a year, like I said, to keep them going. But when they lose that mobility, they become more dependent on their caregivers and the staff to perform those functions for them. Then that leads to a loss of independence, and then you have a high incidence of depression. So those are the 2 areas that I see. Okay, we have a question for Dr. Kobahi. Should the use of carbilevodopa be delayed or reserved for patients with advanced Parkinson's disease only?
Thank you. That's a great question, because back in the 2000s, there were these several large studies done that reported delayed development of motor complications. And like Christina was saying, motor complications being the freezing, the wearing off, these involuntary dance-like movements they might experience. So they found that delayed development of these when the use of carbidopa-levodopa was delayed. But what they didn't realize in follow-up studies was that it was reported that once patients did start their carbidopa-levodopa, they developed the same motor complications, same severity, same rate, whether they started earlier or later. And this finding, plus taking into account the side effects of the dopamine agonist that we went over, the hallucinations, the sleep attacks, and then impulse control disorders, this has led many physicians to switch to earlier use of carbidopa-levodopa as monotherapy, especially in patients that are older than 60 years old. And furthermore, like Christina was saying, it's so important to keep the patients moving, and delaying carbidopa-levodopa at a time when it could be the most impactful for the patient, you get a reduced amount of efficacy. They experience low mood, they're slowing down, they have increased incidence of falls and rapid functional disability. So it really deprives patients of therapeutic benefit early in the disease when the potential for sustained improvement is the greatest. So it's difficult to delay. I wouldn't recommend delaying it unless the patient is really young and it's in early stages and they don't have that much functional disability yet. Then you can always start a dopamine agonist, and then eventually all patients end up on carbidopa-levodopa.
Okay, great. Thank you so much for that. We have another question. This one's for me, Christina. What are some of the more specific diet recommendations for Parkinson's patients? Well, like I said previously, there's no specific prescriptive diet. The best diet is a balance of all the fruits, vegetables, grains, but something more specific that they need to be aware of and to teach their patients is to avoid fad diets. We know that patients on fad diets have fluctuations in weight, energy level. It's just not healthy. The other thing is to avoid sugary foods. We hear that a lot for ourselves, but it can negatively impact your immune system and provides just empty calories. Eating foods with plenty of fiber is good to counteract the constipation that comes from Parkinson's disease, as well as the medication side effects. Eating food that are high in antioxidants is good for overall brain health. And then avoid alcohol due to the medication interactions and effects that it has on the Parkinson's symptoms. For some Parkinson's medications, taking too closely to a high protein rich meal may interfere with the absorption. So it's recommended to have a 30-minute period around a protein rich meal. The other thing is about weight control. Obviously, the more weight you're carrying around, the harder that's going to be, especially when you're having those wearing off periods and they're finding it difficult to move. So later in Parkinson's disease progression, then the swallowing becomes an issue. So then we have more of a weight loss being challenging. Staying hydrated is extremely important. But drinking water can lead to urinary urgency and frequency. So we know a lot of our elderly patients want to avoid that. They want to avoid trips to the bathroom, getting up at night. So we can encourage foods that are high in water content, like cucumbers, zucchini, lettuce, spinach, okra, and then fruits like grapefruit, strawberries, and watermelon. Those are things we can tell the families to bring in as a snack. And thank you all so much for sharing your knowledge, all of you on the panel today. We've learned a great deal, and we are giving you a virtual round of applause. For the attendees, please tell us what you thought of the webinar, but via the evaluation that can be accessed on the GAPNA online library. And be sure to print off your certificate of attendance. Be sure to also visit our website, www.gapna.org. If you have any additional questions or comments, please contact the GAPNA National Office. Thank you all for joining us today, and have a pleasant afternoon.